Hello everyone, this is Dr. Hemnest again. Let us continue the discussion on empirical antibiotic therapy. Okay, today's topic is gastroenteritis, that is diarrhea, right? Diarrhea can be acute, persistent, or chronic. Okay, acute diarrhea when it is less than 2 weeks. It is abrupt onset of 3 or more loose stools in a day or more than 400 grams of stools in quantity. That is called as diarrhea. Either it can be watery diarrhea or bloody diarrhea, right? Acute bloody diarrhea when there are symptoms like abdominal pain, tenesmus, and scant frequent stools with blood and mucus in it. So this is bloody diarrhea. And persistent diarrhea for 2 to 4 weeks. Chronic diarrhea more than 4 weeks. One more entity is there, Clostridium difficile associated diarrhea. Now, when we suspect patient with prolonged or worsening diarrhea after contact with the healthcare system or any history of recent antibiotic use. Right, we suspect for severe CDAD if the total count is more than 15,000 and creat is more than 1.5. Right, that is patient is going into AKI. And we have to suspect for fulminant CDAD if there is hypotension or shock, ileus and megacolon. Right, we'll see some of the specific tests when you suspect for certain bacteria or any infection. What are the specific tests we go for? In cases of Vibrio cholerae, if there is outbreak in the locality, then you have to go for hanging drop to look for darting motility. Right? For bacterial infections like Shigella, Salmonella, Campylobacter, you go for bacterial stool culture. If you are suspecting for coccidian parasite causing the chronic diarrhea, especially in the immunocompromised state, for those we have to do modified AFB stain, that is acid fast stain, right? And you can do stool microscopy to see ovocyst or oocyst of the coccidian parasite. Next is Clostridium difficile. If you are suspecting, for those cases you have to do stool ELISA and PCR to confirm the infection. Next is if the patient is having septicemia or immunocompromised and you are suspecting for enteric fever, then you have to do blood cultures. Right. Now coming to the management, acute diarrhea, acute watery diarrhea that is less than 2 weeks, as I said, you have to suspect for etiology like Staph aureus, Bacillus cereus, norovirus, rotavirus, Vibrio cholerae and enterotoxigenic E. coli. Usually the antibiotics are not necessary. Symptomatic management will subside the symptoms by itself. But there are some exceptions for this, like severe disease. When do you call severe disease? If the patient is having fever which is high grade, more than 6 stools per day, severe volume depletion is there, and host factors like cardiac disease or immunocompromised state or elderly patients in those cases, and also if there is a cholera outbreak settings in your locality. Right, in those cases you have to give antibiotic. So what is the preferred antibiotics? Tablet azithromycin. If there is a cholera outbreak, 1 gram stat you have to give. With that tablet ciprofloxacin 500 mg BD for 3 days. This is the preferred regimen. Right, usually single antibiotic, that is fluoroquinolone, ciprofloxacin, ofloxacin is enough for 3 days treatment. Right. Alternative is tablet doxycycline 300 mg stat for cholera and tablet azithromycin 500 mg OD for 3 days. This is the alternative regimen. Now coming to the bloody diarrhea, so etiology will be different here. As I said, symptoms like abdominal pain, tenesmus and scant frequent stools with blood and mucus will be there. So etiology here will be STEC, that is Shiga-like toxin producing E. coli. Then enteroinvasive E. coli, Salmonella species, Shigella, Campylobacter, Entamoeba histolytica and Yersinia species. The treatment is same, tablet ciprofloxacin 500 mg BD for 3 days. Single antibiotic is enough for this etiology. Right, alternative to this is tablet azithromycin 500 mg OD for 3 days, or injectables like ceftriaxone 1 to 2 gram OD for 5 days, or tablet cefixime 200 mg BD for 5 days. Okay, now coming to the persistent or chronic diarrhea. What are the causes? Usual causes are, first one is cryptosporidium, mostly in the immunocompromised patients like HIV or diabetes. In those cases, these are common. So how do you treat it? In the immunocompetent patients, you treat it with tablet nitazoxanide 500 mg BD for 3 days. But in immunocompromised, you have to give the treatment for 14 days with tablet cotrimoxazole, double strength tablet you have to give 1 to 2 tablets BD for 14 days and followed by secondary prophylaxis. Okay, and you have to monitor the CD4 count also and the viral load, right? HIV if you are concerned. And secondary prophylaxis, the dose is double strength, 1 tablet thrice weekly, 3 times a week you have to give as a prophylactic dose. Then Giardia lamblia. How do you treat? Tablet tinidazole 2 gram single dose is enough, or tablet nitazoxanide 500 mg BD for 3 days, or metronidazole 200 mg TID for 5 to 7 days. Right. Next is microsporidia, tablet albendazole 400 mg BD for 21 days. Right. Next we will discuss about CDAD, that is Clostridium difficile associated diarrhea. Right. Now if the patient is having initial episode, we have to treat differently. Initial episode which is fulminant, like shock is there, ILS, megacolon, hypotension, and first recurrence and secondary or subsequent recurrence. So the treatment differs in each case. So initial episode, if it's there, you have to treat with capsule or tablet vancomycin 125 to 250 milligram 4 times a day for 10 days. Right. If the vancomycin is not available, you can use metronidazole also, that is 400 mg orally 3 times a day for 10 days. Right. In fulminant cases, that is in the shock, we have to increase the dose. Vancomycin 500 mg you have to use 4 times a day by mouth or by NG tube if the patient is not taking orally. With that IV metronidazole 500 mg 3 times a day if oral therapy can't be given. Okay, vancomycin you have to prefer orally only, because we want antibiotic to act locally inside the intestines, right? But if there is first reoccurrence, we have to give a 3 months therapy, guys. A prolonged taper and pulsed vancomycin regimen is used here. What is that regimen? 125 mg 4 times a day per day for 2 weeks, that 10 to 14 days. Then next 2 weeks, next 1 week, what you do is 2 times per day. From 4 times, you made it 2 times. Now, the next week, again, you have to do it 1 time per day. And then 2 to 3 days for 2 to 8 weeks. That is a total of 3 months you are treating the patient. Right. So, but if there is second or subsequent recurrence, you can either give 3 months therapy, but you have more options like 1 month therapy, but with 2 antibiotics. That is, first you give tablet vancomycin 125 mg QID for 10 days, as we do initially here also pulse therapy, but followed by rifaximin 400 milligram TID for 20 days. So making it total of 1 month therapy. Right. Or latest treatment options are fecal microbiota transplantation, right, which we don't do here, but in the higher centers they do it. Right. So these are the discussion on gastroenteritis. Do read about it.